Okay, let's get straight into it. Here we have the clock. We all know that time is relative. It helps, for example, to overcome or to process things. But for us, reproductive specialists, and in general regarding the desire to have children, is the biggest obstacle. Women around the globe postpone childbirth until later in life. Due to this fact, they're more likely to face problems regarding the ovarian function and ovarian insufficiency by the time they're ready to have children can occur. Moreover, the tendency of unwanted influences of environmental and also social factors leads to increases of the incidence of early menopause, and by far female age is the principal limiting factor of success for a spontaneous conception. That's one of my favorite publications from the last years. It was from 2012. It was a very big study. Almost 60,000 blastocyst embryos on day 5 were examined with a biopsy, and they saw that alongside a reduction in numbers, the aging oocytes are also more prone to errors in DNA synthesis and cell division, resulting in increased rates of unhealthy embryos. With unhealthy, I mean aneuploidy, embryos that doesn't have the proper amount of chromosomes. You can see it very clear here. We know that when a woman is around 20, almost 70% of the blastocysts that she produces are healthy, have the proper amount of chromosomes. When she is 35, almost 50% of those blastocysts are healthy. When she is 40, 30%, over 42, less than 10%. We can see it here very clear on the graphic of the female age, the increase of aneuploidy, not proper amount of chromosomes, like Down syndrome, like Klinefelter syndrome, like Turner syndrome. Also, the live birth rate drops because of the low quality of oocytes, of eggs. You can see here in the graphic that with egg donation, the ratio is stable because she has the chances of the donor. And we can draw also some conclusions, like that the endometrium and the receptivity nearly are not affected by age. That's the reason why egg donation works in this constellation. When a woman comes to me and wants my advice about the situation, the first thing that I ask is, how is the ovarian reserve? The things that I take in account is age, the antral follicle count, and the AMH. All of them are very, very, very important to predict how this cycle will be with us. Also, from the graphic, we can see that from the puberty until the menopause, it's a time span of 40 years, more or less 500 evolutions occur. And in each evolution, 1,000 oocytes get recruited, but only one gets selected. The rest are lost. There's a big problem. So, in most of the cases, we have a problem of quantity and also of quality of the eggs. To solve this problem, our reproductive doctor or assistant can offer the solution egg donation with really excellent results. Such a solution, but can pose for some couples a significant psychological, also financial concern. Also, religious beliefs can be a hindrance for egg donation. Legal restrictions in many countries can also be an obstacle for egg donation. For this reason, the possibility to restore the ovarian function is crucially important So our goal is enabling women to become mothers with their own eggs. Let's go now to our key question. Can the ovaries be rejuvenated? Is it possible to rejuvenate them, to have again follicles there? Also because of the fact that it's a non-effective treatment to prevent, delay, or reverse ovarian senescence exists. Several ongoing trials are investigating approaches to rescue or regenerate oocytes and restore fertility in women with ovarian insufficiency. Like in vitro oocyte activation, like stem cell therapy. Also, others exist that, from the ethical point of view, they are not justifiable, like germ cell line manipulation. So, the way to go in many clinics is the use of platelet-rich plasma. The advantage is it's cheap, it's easy to apply, almost without risk, and the results from the first studies are very promising. Let's see what platelets are. That's the first step. Platelets are small fragments from bigger cells, the precursors, that are the megakaryocytes. Although traditionally considered as agent for stopping a bleeding, let's say we have here an injury, that's a vessel, what you see. Platelets attach to the damaged wall, and they produce a blood clot, sorry. And they release many different factors, growing factors, cytokines is the name. And they play also, besides of stopping the bleeding, a very, very crucial role in the repair and the generation of various tissues. Here you see also platelets. There are over 50,000 proteins that are inside of the platelets. Among them are growth factors. They're stored all in granules, which are known to play a very important role in normal healing. About PRP now. PRP is composed of platelets in a small volume of plasma containing high concentration of platelets, derived growth factors, and cytokines. It was first used in open heart surgery in '87, and now it's widely used in many areas of medicine, in a wide field, like orthopedics, traumatology, cosmetic surgery, etc., etc. Now, the question is, how does PRP work? There are several possible explanations for the reversal of aging ovaries that have been proposed. The first thing is the interaction with ovarian germline stem cells. Some years ago, the idea was that inside of the ovary, stem cells doesn't exist. Stem cells have the power to produce new cells, and the belief was that in the ovaries those cells doesn't exist. But the last years they were discovered, and the idea behind PRP is that those stem cells get activated by the growth factors within the platelets. The second explanation how PRP works is that it can promote folliculogenesis. That's another possibility, and the idea is that some amount of follicles, dormant follicles, are still in the ovary, and they're also get activated, and they promote that new of them get produced. Let's see here this picture. It's very interesting. You see here an ovary. Here is a follicle, the maturing egg, and here the granulosa cells. Maturing egg. Here we have the tissue, the interstitial tissue, the functional tissue of the ovary. And the granulosa cells, inside of them are the growth factors. The growth factors. When we inject, for example, PRP here in the interstitial tissue, they have an effect at all neighbor cells, and the result is that the nutrition, the blood perfusion, and the hormones get boosted. Another very interesting question is, and I think that's the question that you ask yourself if you're a candidate for this book. The best groups to receive PRP so far are those 4 groups. One group is the group with low ovarian reserve. The other group is women that face the problem of premature ovarian failure. It means that they are very early in the menopause, before the age of 40, and the prevalence is increasing. Now it's 1 of 100 women. One other group are the women that are in the perimenopause, and another group are the girls. They are the women that are in the menopause. Now, how is ovarian rejuvenation performed? The first step is the collection of the blood. Okay, then we separate the platelets, and with a centrifugation here, we separate the white blood cells and the platelets. And we get the platelet-rich plasma, and it gets then injected into the ovaries. It's the own blood of the woman. So we inject own material. It's nothing from another person. So the reaction to this is unlikely. I didn't saw any reaction so far, any allergic reaction or any immune reaction. You can see here in real life some pics from our lab. Here it's exactly the same. The centrifugation here. Then we separate the material. We have the PRP. We got it, and then it's ready to get injected. We do that fresh the same day of the injection. You see it here. It's ultrasound guided. Here's the ovary. Here's the needle, the white line that you see, and we inject them directly in the ovary. Now I want to share with you some publication of the last years. They're my favorite publication, and they are very promising despite the low participant numbers. The first is from a group from Turkey, Mr. Sakiroglu and his group. They aim to determine whether PRP improves the response to ovarian stimulation and in vitro fertilization outcome in women with primary ovarian insufficiency, women that got earlier in the menopause before 40. They included 311 women between 24 and 40, and they got with PRP injected. The results were that 201 women, it was almost 65%, developed new follicles and attempted IVF. 7%, for 7%, it was possible without any treatment to have children, and around 28% didn't produce any new follicles. So therefore, they did not receive additional treatment. So it was quite promising. The second study is from the group from Dr. Mello. They aimed to investigate the impact of the 3-month course of PRP, ovarian injections, upon ovarian reserve markers, AMH, FSH, and also the follicle count for patients with a low ovarian reserve before undergoing to new cycles. They find out in totally also a small sample, 82 women were included, of which 46 received PRP treatment and 37 underwent no intervention. After this 3-month course with PRP, they saw that those markers increased 26% for the group that received PRP and 5% for the group that didn't receive. Also, the clinical pregnancy rate also increased with the group that received PRP, 24% versus 5%. And also, the conclusion was that PRP is very safe, very effective, and if we speak about improving markers. Regarding the live birth rate, they didn't see any difference, most likely because it was also a small sample of patients. The third study is a study from the US, from Mr. Shields. It was the first study who described that the PRP technique for low reserve was very promising and safe, and it was associated with significant increase in AMH for some patients, usually within 4 weeks. They saw in 51 patients an increase of 160%. And now my favorite study is the study from a Greek group, Mrs. Roukoudis. They were included 4 pilot studies. One study was for patients with poor ovarian response. One study for patients with also premature ovarian insufficiency. One group that was in the premenopause, and one group that was in the menopause. Each pilot study had 30 patients, in total 120. And they saw that in the group of the poor ovarian reserve, the parameters like AMH, AFH increased. Most important, 12 out of 30 patients achieved a live birth following a single ICSI after PRP. In the group with the premature ovarian insufficiency, 60%, 18 women, positively responded to PRP treatment, also with an increase of the reserve markers. And 3 out of 30 achieved another normal conception and a live birth. In the group of perimenopause, 24 women responded positively to PRP, and that was with restoration of the menstrual cycle, also with increased markers of AMH, of follicle count. And following this PRP treatment, 4 participants achieved a natural conception. And from those 4, 3 had a live birth in the group of the perimenopause. In the group of the menopause, 13 women also positively responded to PRP treatment, the same as in the perimenopause, and 1 out of them had a natural conception. Yes, it's very impressive if you consider that they're women, they're in the menopause, they are 50, almost 50, and before that they didn't have any menstruation cycles anymore. So only with this PRP treatment to see that 1 out of 30 achieved a natural conception is remarkable. Then a systematic review came out. This systematic review included all the 4 before mentioned. In total, 663 subfertile women who intervened with PRP. And this data confirmed the findings of the authors that ovarian reserve parameters improved after PRP intervention, PRP infusion, leading to increased oocytes, fertilization rate, and ultimately formation of good quality blastocysts. Last but not least, this study, it came out at 2020 in June. It involved 38 women, 31 to 45, also with a low ovarian reserve, and at least 2 unsuccessful attempts with IVF. 1 single PRP treatment occurred, and several criteria were tested for 12 months. And they showed also a significant improvement of hormone levels. Many women showed a dramatic improvement of AMH, up to 1,1 compared with 0,0 nanogram per milliliter before treatment with PRP. 10 pregnancies were achieved. 4 out of 10 were from natural conception, and 6 healthy babies were born. Here is to highlight that one difference that was shown is that the concentration of platelets were much higher than in the studies before. So, since it's still an experimental therapy, there is no standard protocol. This fact explains also the different outcomes in the various studies. Difference exists in the exact time of application during the cycle. Regarding the platelet concentration that is achieved and injected in the ovaries. In some studies, it was 1 injection. In other studies, it was a course of 3 injections. Also, the technique, how to inject, how very, very exact to inject. So it's, how I said, no standard protocol exists so far. Now, what we're trying to achieve here in IVF-Spain is to start a very, very promising and ambitious study. I'm very proud to announce it, I must say, with autologous conditionate serum. It's after processing PRP, we get this AAS, and this discharge of those concentrated granules, they're inside of the platelets, release a number of growth factors and cytokines in physiologically relevant proportions, but in concentrations much higher than in the most studies. And so we guarantee a much higher concentration for injectors. With this study, we aim to demonstrate the efficiency and safety of intra-ovarian administration of autologous conditionate serum for ovarian tissue regeneration. The inclusion criteria will be the following. The patients must be between 20 and 50 years old and meet one of the following conditions: early ovarian failure patients before 40 years, idiopathic origin, not that it comes from, let's say, after cancer treatment. The natural menopause in patients between 40 and 50 years of age, low ovarian reserve. With that, I mean AMH below 1,1, antral follicle count less than 5, and previous low ovarian response less than 3 with a cycle. Then patients with a low prognosis who subsequently undergo in vitro fertilization treatment without a low ovarian response reserve. For example, history of failed cycles due to a poor oocyte or embryo quality, low blastocyst development rate, low euploid embryo rate. The exclusion criteria will be the following: ovarian insufficiency due chromosomal, genetic, or autoimmune causes, chronic issue of anticoagulants, ovaries with a poor access. Here, if a laparoscopic administration is possible, then we will include them. History of cancer or active tumor processes, severe obesity, BMI over 35. One reason is that also the access will be very difficult. Psychiatric disorders or initial pregnancy. Now you will ask for sure, what's the difference to the other studies? The difference are that it's the first pilot study with a large patient population. So that will allow us to draw realistic and pragmatic conclusions regarding effectivity of this method. Then the thing that I mentioned before, that with a further processing step of therapy, we get this autologous condition at zero that can guarantee high concentrations of those growth factors. Then also it's conducted in a clinic with a high level of expertise in the field of studies. And also all the centers of IVF-Spain will contribute. Now, what are the specific objectives? Improvement of the ovarian reserve markers and egg quality, determined by monitoring of the hormones and also with a scan. In addition, restoration of the menstrual cycle and or natural conception with patients with a natural menopause or with a premature ovarian failure. Then improvement of embryological and reproductive outcomes after regenerative therapy in patients with low ovarian reserve or poor prognosis for underwent IVF cycles. To say it simply, to have a higher fertility rate, for example, or a higher development to day 5. Regarding the application, the timing, one approach will be at the beginning of the menstrual cycle in patients with regular cycles, or at any time in patients with ovarian insufficiency. The other possibility is for patients with a low ovarian reserve who follow an embryo of accumulation strategy to get as many embryos as possible and test them all genetically. This, with the follicle puncture, we can also inject this PRP to reduce also cost after the accumulation of the follicles. I have an example for you so that you can better understand it. You see here, that's an example for the accumulation strategy. For example, we start with a priming, like an anticonceptive pill. We have a menstruation. The idea of the priming is to have follicles with the same growth and all of them to be the same sensitive to the stimulation. Then normally we start with stimulation. We do in the end of the stimulation, the recovery, inject the the autologous serum. Then the woman will have again a menstruation. We wait 3 to 6 months for this PRP to work. It's very crucial. Next menstruation, and we start right away then with the stimulation of the second stimulation. Here is expected that we gain more oocytes, have a higher fertilization rate, get as many as possible to day 5, and all of them to test them genetically. Because here's not to forget that we work with women with a higher ratio of unhealthy embryos, of blastocysts. It's crucial to do the genetical testing to exclude the unhealthy one and have only the healthy one to transfer. Now, the post-intervention follow-up. 20 to 14 days later of the administration, we will perform a scan to see the changes in the ovarian morphology, and we measure the hormones to see the restoration of the hormones, that the markers for reserve increase. About the management. Let's say we have positive results as expected. Positive changes in the ovarian scan, increase of AMH or decrease of FSH. In this case, IVF treatment should be started immediately with ovarian stimulation, with conventional doses of low or lower doses, depending on the number of antral follicles detected. Those patients who do not plan IVF treatment will try to conceive naturally if the other conditions are allowed, like that the tubes are working normal or that sperms are good. If the results are not positive, we will do a follow-up up to 6 months, and depending, we will do 1 or more consecutive administration of the serum according to the procedure described above. Maximum 3 applications within a period of those 6 months. Now, about the potential. The impact of and development of the application of this serum, this therapy, would be very large and would increase the pregnancy expectation of this type of patients. Still, how I said, it's experimental. Maybe in the near future, we work on that. It will be a really alternative to egg donation with further research and refinement of the procedures. But egg donation, to be honest, until this point, has higher success rates. Also, one other question that's also ethical and we must face with those new techniques and the new possibilities that are there is a controversial discussion regarding the age limit at which fertility treatments may be used. With the for egg donation here in Spain, it's allowed for, until 50, 51. It will be the same for this treatment if it proves that their effectivity. It's a very interesting discussion, and I'm sure that with improvement of the techniques and with refinement of the procedures, we must face it. Here you see all our locations in Europe, and I came to the end. Thank you very much for your attention. Good. It was a pleasure to have you with me today and to present you this very interesting topic. If you want further information, please contact us. This is our email, and it would be a pleasure to bring you this topic in detail, and also to say to you if in your case it would be recommended, and to answer all of your questions. All the other questions, I will do my best and answer them via email. I wish you all a nice evening and all the best. Bye-bye.